The next is newer treatments in diabetics. A lot of changes have come in the year 2009. New drugs have come. New injectable drugs have come. Many guidelines have changed in the year 2009 in the field of diabetes. And we have with us an expert in endocrinology in diabetes. In fact, two experts in diabetes. One is going to moderate and one is going to speak on that. I'll first request Dr. A K Jhinghan to please join us to moderate this session. Dr. Jhinghan's name you can synonymize with Diabetes Mela in Delhi. He is one person who has devoted his life in creating awareness about diabetes. Whether it is Ramzan, whether it is Diwali, whether it is Navratras, what you should eat, what you should not, you will find Dr. Jhinghan appearing in most of the newspapers. When it comes to surveys, whether it is in the government offices or in the schools, all surveys, somewhere you will find the name of Dr. Jhinghan. Please join us on the dais. And I have with me Dr. Ambrish Mithal, an expert who all these years was with Delhi's Apollo Hospital. But in the last couple of weeks you have seen messages that he is not only in Apollo, he has also joined hands in Medanta group of hospitals, which is in Gurgaon, the dream of Dr. Naresh Trihan. So he is now attached with both Apollo group of hospitals as well as the Medanta group of hospitals, because I know they are almost acquiring a lot of hospitals in the country. I ask Dr. Jhinghan to start and then invite Dr. Ambrish Mithal to take over.
Thank you, Dr. Agarwal, for a kind introduction. Good morning to everybody, and I am really, first of all, thankful to Dr. Agarwal for making such an important session and for interactive and something which is more important in the field of diabetes. As we all know that the number of patients have doubled in the last 15 years, more focus is based on the etiopathogenesis, that either insulin resistance has to be taken care or we have to take care of the beta cell function. And that's why the most of the medicines are now focused on such which drug to use, when to use, and how to start a drug. I think there is no better person and authority on diabetes. We have, and I have a pleasure in introducing and inviting my friend Dr. Ambrish Mithal, who is now the chairperson of endocrinology department in Medanta, that's the Medicity Hospital, or one with the institution, great institution which Dr. Trihan is bringing it. And at the same time he's also having he's attached with the Apollo Hospital, and both the big hospitals, he's one of the leading experts in the field of endocrinology. I'll request Dr. Ambrish Mithal to please.
Good morning, everybody. I'm pleasantly surprised to see so many people here on this cold, wintry morning. I'm normally happy if the chairperson has arrived and the speaker is there and the organizers. That makes about 5 or 6 people. And we are used to giving talks even in that setting. But it's a pleasant surprise to see so many people interested in new developments in this area. Dr. Agarwal, as usual, never makes things easy, and he gave me a topic, What's New in Diabetes 2009, which is actually there's lots that's new. So I had to pick and choose a couple of things, and I thought I'll choose only 1 or 2 areas which are of direct interest in clinical practice to all of us, to specialists and non-specialists alike. If you look at the 3 major changes, and Ashok can correct me if I'm wrong, is the major advances in 2009 is the acceptance of the American Diabetes Association to use HbA1c as a diagnostic modality. We've always used HbA1c for monitoring. There is a suggestion, not universally accepted though, but Americans are saying you can use HbA1c purely for diagnosis also. There has also been a flurry of papers on changing targets for glycemic control. You see, there was a lot of, over the last 5-7 years, it has been the norm that in ICUs you try to maintain blood glucose between 80 and 110 and all that. And in the OPD also, the HbA1c targets kept coming down, 7 to 6.5, 6.5 to 6. Recent data indicates that we've probably gone overboard in terms of inpatient ICU patients. When you're looking to target glycemic control, it is pretty safe to, in general, keep them between 140 and 180. And there is no need to be obsessive about keeping them at 90 or 80, which leads to more hypoglycemia and more complications. So one is for all of you who would be practicing in ICU settings, target blood glucose control is in ICUs are anywhere between 140 to 180. Up till 110 at the lower limit is okay, but there's no need to target to 80, 90, which had become the norm in some ICUs, leading to more hypoglycemias. In the outpatient scenario also, not everyone should have a target of 6 or 6.5 HbA1c. As we know, HbA1c reflects last 3 months diabetes control, and it's a very accurate reflection of that. So even in the outpatient setting, in the patients you treat in your clinic, 7 is a reasonable target. Some patients who are newly diagnosed with no complications, we should aim for even tighter control at 6 and 6.5. But your older patients who have heart disease, who have already had diabetes for 15 years, it is not necessary to bring them to fastings of 90 and PPs of 140. You know, if you're maintaining A1Cs of around 7, which means fastings of 120, 30, PPs of 160, 70 is also acceptable. So you have to target your goal or change your target according to the patient. A newly diagnosed 30-year-old diabetic, where you want really tight control, is acceptable. A 70-year-old diabetic with 15 years history and heart disease, you may want a moderate level of control. So those are the changes that have taken place based on a lot of studies that have come out. So I think those 2 points should be clear. Also, the last point which I'm going to talk about now is really there is actually been changes in drug choices, and greater use of incretin-based therapies, which I will briefly explain to you what do we mean by incretin-based therapies. And that will be the focus of the talk today. What we mean by this is 15 years ago, when you and I were 20 years ago learning diabetes, it was very easy. You had glimepiride, maybe one or two other, glibenclamide and some other oral anti-diabetics, and you had metformin and you had insulin. So life was very easy for the practicing diabetologist, endocrinologist, physician. But it has changed. Over the last 7-8 years, there have been a multitude of drugs that have come out and which have given us a lot of choices in treating diabetes. At the same time, it is not 100% clear that this drug is superior to the other and this is better than the other. So it's like the same thing. When you go and buy a shoe or a shirt, one size does not fit all. You can't say 38 size is the best shirt, everyone has to buy that. And this is the best brand, you have to buy this. You have to choose for your patient. You have a multitude of choices. You have to choose for your patient what fits better for this particular patient. Individualized therapy based on patient profile. So I will now, next few minutes, talk about incretin-based therapies, which are the major change. They came in a few years ago, and in last 1 year, they have actually changed the way we treat diabetes to a large extent. And in that recognition, the American Association of Clinical Endocrinologists has now changed its guidelines for management of type 2 diabetes. And we will end with those guidelines. So what is the main problem? When you treat type 2 diabetes, if I were to ask you as a physician, any one of you, you must be treating diabetes. What is the biggest problem you face in type 2 diabetes? The biggest problem we face in treating type 2 diabetes is that as type 2 diabetes progresses, beta cell function declines, the blood sugar tends to deteriorate, the HbA1c tends to rise, and the third point is that most treatments you use right now, the current treatments for type 2 diabetes are associated with either weight gain or with hypoglycemia. With the exception of our gold standard metformin, good old metformin, which produces neither weight gain nor hypoglycemia, every treatment you use, even insulin, whether you use insulin, whether you use sulfonylureas, which we have used for so many years, or you use the thiazolidinediones, the pioglitazone, rosiglitazone, you will find either weight gain or hypoglycemia or both. So that is the biggest challenge. If that was not a challenge, you would just give a lot of medicine to everybody, the sugars would be okay. There is no problem. Double the dose, sugars will be okay. The problem is if you do that, you get low sugars. The problem is if you push the medicine too hard, you get bloating and weight gain.